Everybody, gonna get into a walking blood bank research session here. I've got some content that I can share with y'all, and this is pretty much not to leverage myself as like the know-it-all. This is kind of like a study slash research session for me to get familiar with the content. And for me, the best way to do it is if I'm using technology to kind of archive this research session and also to be able to save it somewhere where I can access it later. And that favorite spot for me is YouTube, my own YouTube channel. And who knows, someone else might look up this type of information uh, and learn from it as well, even though it's just me sharing the process of me researching it, if that makes any sense. So I'll get all of the slides later, but right now this is just notes. What this channel is called, Sidenotes. I'm gonna try to create a blog for it also, but that will take some time. So special considerations: blood and blood components should only be administered by personnel who are trained in the proper procedure and the identification and management of transfusion reactions. As little as 30 milliliters of incompatible blood or red blood cells can cause a fatal hemolytic reaction. Green card donors can be given to anyone because they are universal donors, they are O negative. Red card donors must only be used for matching ABO blood type, which is A, AB, or AB positive, AB negative. Th- those categories of blood types. Use only collection bags designed for the collection of whole blood, and administration sets designed for the administration of blood and blood components. Okay, next slide. So, more special considerations. The only solutions approved by the FDA and AABB for use with blood and blood components and normal saline and plasma light 148. Lactated ringers has been shown to be compatible but is not approved for use by the FDA or AABB. When administering fresh whole blood, additional fluids are not required for administration. Sterile technique is recommended but not always possible in the field. Sterile technique is recommended but not always possible in the field. Combat clean is the minimum standard. Overview. Whole blood is blood that has not been modified except for the addition of an anticoagulant. Whole blood provides the equivalent of fresh frozen plasma, RBCs, and platelets in a 1:1:1 ratio. Fresh whole blood will have a shelf life of 24 hours and should be transfused immediately or stored at 33 to 43 degrees F 1 to 6 degrees Celsius, 43 degrees Fahrenheit or 1 to 6 degrees Celsius, within 8 hours after collection, unless otherwise directed by medical staff due to insufficient or no red blood cell or plasma product inventory. Identify a blood donor who is ABO identical with the intended recipient, ABO identical, not RH identical. Whole blood is sometimes referred to as fresh whole blood if it has been recently collected. However, there is no time standard as to when it is no longer considered to be fresh. It is also referred to as warm, fresh whole blood when it is still warm following collection. Prior to initiation of transfusion, the following should be checked: vital signs, temperature, pulse, respiration, blood pressure. Measure, evaluate, and record baseline vital signs. An increase in temperature may be the first indicator of a transfusion reaction, but is also common during blood transfusions. Casualty blood type should be confirmed by matching red and ABO types or using a green donor if patient has no blood donor card. Eldon card test should only be used as a last resort when no green card donor is available. Active measures should be used to prevent casualty hypothermia. Transfusions. Ideally, blood products should be warmed to approximately 98.6 degrees Fahrenheit or 37 degrees Celsius prior to transfusion. Do not exceed 102 degrees, as this may cause an inflammatory reaction and lose some of the red blood cells. Cold blood may cause cardiac arrhythmias. Blood may be pressure infused during a pressure infuser that encases the entire blood collection bag. Do not exceed 300 mmHg with the pressure infusion device. The largest bore IV catheter should be used. An IO device may be used. Ensure that a strong flush is done and good flow is obtained prior to using an IO infusion. Minimum size for emergency whole blood infusion is 20 gauge catheter. When performing any administration of blood or blood components, the patient should be continuously monitored for signs and symptoms of an immunologic blood transfusion reaction. The first 10 to 15 minutes of any transfusion are the most crucial. Transfusions. Acute hemolytic transfusion reaction. Acute hemolytic reaction usually has onset with 1 hour. Evidence of disseminated intravascular coagulopathy oozing from blood draw IV sites, flush especially in the face, fever and increase in core temp of more than 2 degrees Fahrenheit, shaking, chills, rigor, flank pain, or the acute onset of pain in the chest, retrostomal, abdomen and thighs, wheezing, dyspnea, anxiety, feeling of impending doom, nausea and vomiting, hypotension, pain, inflammation, and or warmth at the infusion site. Transfusions. Acute hemolytic transfusion reaction. Acute hemolytic reaction usually has onset with 1 hour. Evidence of disseminated intravascular coagulopathy oozing from blood draw IV sites. Red or brown urine is called hemoglobinuria. Hemoglobin urea. Hemoglobin urea. Hemoglobin urea. Hemoglobin urea. Hemoglobin urea. Hemoglobin urea. The onset of red urine during or shortly after a blood transfusion may represent hematuria, indicating bleeding in the lower urinary tract, or hemoglobinuria, indicating an acute hemolytic reaction. Treatment for acute hemolytic transfusion reaction, AHTR. Immediately stop the transfusion. Initial treatment. Secure and maintain airway. Begin an IV infusion of lactated ringers. Do not run any fluid through the line that was carrying blood. The goal of fluid resuscitation is to maintain a urine output of 100 plus ml/hr until the urine is clear of hemolyzed RBCs. Transfusions. Consider using acetaminophen, 1 gram PO, PR, or IV with fevers. Administer 25 to 50 mg of diphenhydramine IM or IV to treat the associated histamine release from AHTR and help manage the chills and rigor. Save the rest of the donor blood and any typing information available and evacuate with the patient. This will allow for ABO and further diagnostic testing at the medical treatment facility. Man. Febrile non-hemolytic reactions. Fever not as severe as with an acute hemolytic reaction. Chills, dyspnea. Treatment for febrile non-hemolytic reactions. Treat with antipyretics, Tylenol, 1 gram, orally or rectally. If symptoms abate and there is no evidence of an acute hemolytic reaction, consider restarting their transfusion. Urticaria reactions. Urticaria, skin rash, notable for pale red, raised itchy bumps. Treatment of urticarial reactions. Treat with 25 to 50 milligrams diphenhydramine IM or PO. If symptoms abate and there is no evidence of an acute hemolytic reaction, consider restarting the transfusion. Man. So, citrate toxicity. I read a more summarized definition earlier, and it was along the lines of calcium. Calcium is the key word. And, whoa, it's getting. There's a party outside. It's very distracting. Citrate works as an anticoagulant for stored blood components by chelating ionized calcium. Citrate works as an anticoagulant for stored blood components by chelating ionized calcium. As citrate in the blood component is transfused, it is rapidly taken up and metabolized by every nucleated cell of the body. Alright, I'm going to have to get into that later. Transfusions. Severe. These are the signs and symptoms. What stands out the most is pressure in the chest. That would be obvious to you. Probably carpopedal spasms, spasmodic contraction of the muscles of the hands and feet, or especially of the wrist. Seizures. Transfusions. Treat for citrate toxicity, mild toxicity, slow or stop transfusion with symptoms until symptoms subside. Severe toxicity, 3 grams of calcium gluconate, slow IV push, or 1 gram calcium chloride. Do not rapidly infuse calcium nor give more than 1 dose without the ability to monitor electrolytes. This may lead to cardiac arrhythmias. Let's see how much more slides. Dang, this is a lot. This is a tough class. I'm going to try a TED Talk to see if that helps me. Some pictures. More pictures. More pictures. Okay, this set that they use is called a schnook. Let's see if there's anything that stands out. So this here, these are the steps for blood administration. I think a lot of this, practical exams is is how most people learn, just by doing it. It's got a constricting band.